Good morning, America. Good afternoon, Europe and Africa, and good evening, Asia and Australasia. My name is Napapong Pongnapang, ISRT Vice President for Asia and Australasia. I am hosting this exciting event today for you guys. And we are here today. We have the special event in cooperation between the ISRT and the American Society of Radiologic Technology, ASRT. And this is the first event that we joined together to run this webinar. And we also have a special speaker that will give a talk on the topic entitled The Radiologic Technologist Accepting the Challenges of Today's Cath Lab. Before going to the program, we have two special guests of honor here. First is Donna Newman, the SSRT president, and also Mike Odgren, the president of the ASRT. Before we move forward to the program, I would like to have the opening speech first from Donna Newman, our ISRT president. Donna.
Good morning, good afternoon, and good evening to all our members from around the world. I'm so honored to collaborate with the ASRT on this special episode, Technologist Accepting the Challenge of Today's Cath Lab. Today, it just makes complete sense to have this great organization collaborating with, as they've truly been leaders, not only in the United States, but in the ISRT. They have advocated for patient safety. They have advocated for workers' rights, especially during COVID. They've advocated for scope of practice within our field. They've not only supported the ISRT by co-hosting the World Congress, but also by collaborating to put on workshops. So I'd like to turn over this program now to Mike Ogren, the president of the ASRT, just to share a little bit about the work that they're doing for the United States and to highlight some of these great programs. Thank you, Mike. I look forward to hearing what you have to say.
Oh, thanks, Donna. Hey, so I guess I want to start by saying thank you to the ISRRT and also to my friend, Donna Newman, ISRRT president, for inviting me. My name is Mike Odgren, and I am the president of the American Society of Radiologic Technologists. And I'm thrilled to be here and doing this today with the ISRRT. This is the ASRT's centennial year. This is our 100th anniversary, and we're just about wrapping it up here. My history, I am a radiologic technologist, and I'm also a radiologist assistant, which is an advanced practice radiographer. I specialize in pediatrics. That's what I do most of the day anyways. So about the ASRT. So right now we have a membership, currently a little over 157,000 members. As I said, we are celebrating our centennial year this year. We were founded in 1920 with 13 members to begin with. Now at 157,000 is pretty spectacular. So like a lot of people, due to COVID-19, we did have to cancel our big centennial celebration that we had planned last June in Albuquerque. We are hoping, with these vaccines now starting to come out, that we'll be able to hold our in-person meeting in Reno, Nevada, next June. And we're going to try and celebrate our centennial then in Reno instead of at our headquarters in Albuquerque. So a little bit about some of what we do. A large part of what we do at the ASRT is provide continuing education for our members. We also write practice standards and scopes of practice for radiologic technologists here in the US, and a lot of those are used in state licensure laws. And the other thing we do is we're big advocates for our profession. So we've been fighting encroachments by other healthcare professionals trying to perform radiography when they haven't had any education or training. And we also educate the public and lawmakers about who we are and what we do. Recently, the ASRT signed onto a joint letter with the Society of Nuclear Medicine and Molecular Imaging and the Society for Diagnostic Medical Sonography, and sent that out to every state health department in our country, trying to encourage them to make sure that radiologic technologists, sonographers, nuclear medicine technologists are all on the first wave of people to get immunizations across the country. So that's just a little bit about us and what we do. And thank you so much. Thank you, Donna, for inviting me.
Thank you so much, Mike Aldrin, the president of ASRT, and our president, Donna Newman. Now I would like to introduce our speaker for today's event, Christopher Stillman. Chris had education from St. Joseph University, also with Westchester State University, and he is currently assistant professor and program director for the Master of Science in Radiologic Science at Weber State University School of Radiologic Science in the US. Christopher Stillman is also the ISRT Regional Coordinator for Professional Practice for the Americas region, and he has a lot of credentials. And today, I am so honored to introduce my good friend, Chris Stillman, for his talk in the first webinar with ISRT, and I hope we're going to have more from Chris. And today's the topic will be the radiologic technologist accepting the challenges of today's cath lab. Please welcome Christopher Stillman.
Hello, my name is Christopher Stillman. I'm an assistant professor at one of the most innovative and advanced School of Radiologic Sciences in the world, Weber State University. One example of that innovation is the Cardiac Specialist Program, the first master's level program dedicated to radiographers focusing on the cardiac cath lab. Today, we'll be talking about the radiologic technologists and how we accept the challenges of today's cardiac cath lab. In addition to teaching at Weber State University, I'm honored to serve the International Society of Radiographers and Radiologic Technologists as their regional coordinator of professional practice for the Americas. It's been one of the greatest joys of my life being the chairperson of the World Radiography Education Trust Foundation, and I'm proud to serve the American Society of Radiologic Technologists Global Outreach Review Committee. I'm obligated to disclose that I have no actual or potential conflict of interest with regard to the subject matter of this presentation. I sincerely hope you have as much fun watching this presentation as I've had making it. Today we'll talk about the history of the cardiac cath lab, and believe it or not, it all starts with Röntgen. We'll talk about procedures being performed that improve the lives of both adults and children. And then we'll talk about the challenges of working in this environment and how we can protect our patients, our coworkers, and ourselves. So let's get started. The heart. Weighing about 10 ounces, slightly less than a can of soda, my entire career has revolved around this amazing organ. Beating 100,000 times a day, pumping 100 gallons of blood throughout the body every single hour. This blood travels through 60,000 miles of blood vessels, and it is simply amazing when you begin to look at the complexity of this small little organ. And yet, it's not perfect. And when things go wrong, we provide an alternative to surgery in the cardiac cath lab. The cardiac cath lab has an amazing history, but it still starts here, the 8th of November, 1895. Without Wilhelm Röntgen, there is no interventional cardiology. Now, we don't have time to go deep into the history of the cardiac cath lab, but there's a couple stories I'm going to share with you. I've been looking forward to telling you this story. Werner Forssmann, 25-year-old surgical resident in a small hospital in Eberswald, Germany. Werner thought it would be more efficient to deliver drugs directly to the heart via a catheter. Yet his proposals for research were denied. Undeterred, Werner recruits Gerda Dietzen to assist him in this first experiment. Together they go to the OR room. Nurse Gerda Dietzen is strapped to the table with the assumption that she would be the first subject of this research study. However, that was never Dr. Forstman's plan. He only needed Gertrude because she held the keys to the locker where the 65 centimeter long urethral tubes were stored. Once strapped down, Warner strolls over to the other side of the OR, makes an incision in his left elbow, and inserts this catheter into his arm. Then, catheter dangling from his arm, he walks over, unstraps Gerda Dietzen, and they proceed downstairs to the X-ray department, where under the guidance of fluoroscopy, he advances the catheter into his right atrium, giving birth to what we now know as the first human cardiac catheterization. The year is 1958. In a basement lab in the Cleveland Clinic in the United States, Dr. Soanes was about to open up a window on the anatomy of heart disease, letting doctors for the first time see diseased blood vessels and a way to potentially treat them. In those days, it was thought that if the catheter tip slipped into the coronary artery, the patient would go into a lethal arrhythmia and expire. But that's exactly what happened. During a routine aortogram, the tip of the catheter slipped into the coronary artery, and for the first time, we saw a coronary angiogram. And when the catheter tip slipped in that artery, Mason Soanes and his team looked up at the monitor and saw contrast flowing through the coronary arteries. In this case, we're looking at the left coronary artery system. This is a beautiful angiogram of the left coronary artery system. This is what we all want to see. No visible lesions, nicely collimated image, contrast being delivered into the left main system, which is bifurcating into the LAD, and the left circumflex. In this case, you can see the LAD is running down the center of this frame. We work under high magnification, and often we're not able to visualize all of the coronary system without moving the patient. So we're actually sliding the patient horizontally under the X-ray tube so that we can capture everything that we need to see in one angiogram. That's a technique called panning, and it's one of the highly sought after and highly regarded skills of radiologic technologists working in the Cath lab. As a result of training and advancements in technology, coronary angiography is now routine. In the previous two slides, we looked at a disease-free left coronary artery system, and then the next couple slides, I'm going to show you what happens when the patient isn't as fortunate. And this is where it starts. We need to be able to deliver that catheter to the artery or any other area of the heart in order to diagnose it or provide a therapeutic intervention. So again, it starts here. We take these small tubes with a one-way valve on them, and they're called sheaths. And by inserting them in the arteries and in the veins, we're able to pass through these one-way valves, devices which help us accomplish our tasks without the patient experiencing a great deal of blood loss. Okay, now we've established access to the human body through the use of a sheath. But now we have to figure out a way to get to the coronary artery. And we do that through the use of plastic tubes called cardiac catheters. They come in a variety of different shapes and sizes, usually dependent upon physician preference and also the anatomy of the patient and the procedure that we're doing. Think of these as tunnels leading from our access point, which is the sheath, to the coronary artery. Once we have that access tube placed, we can now deliver contrast and interventional devices. Well, placing that catheter in its intended destination is not always so easy. Think about this for a minute. That catheter is 100 centimeters long. We take the distal tip of that catheter, insert it into the sheath, pass it, in this case, through the aorta, and now our goal is to line it up exactly with the ostium of the vessel that we're working on. Anatomical variation can make that incredibly difficult. And you can see in the picture on the right-hand side, in that particular case, we tried over a dozen catheters simply so we could access the coronary vessel to inject contrast and other interventional technologies into the vessel. So our routine cardiac catheterization typically involves two components: assessment of the left coronary artery, which we've done by inserting a sheath into the patient's large vessel, whether it be radial artery or femoral artery, inserting a one-way valve or a short tube that allows us to deliver devices in and out of these large vessels. And through that sheath, now we've inserted a catheter, which we've lined up with the ostium, or the opening of the vessel, and delivered contrast. And that's what allows us to visualize potential lesions. And when I say lesions, I'm talking about a narrowing of the artery that's disrupting blood flow distal to that narrowing. And sometimes that narrowing gets completely occlusive or completely blocked. And if you can imagine, if we blocked blood flow to the myocardium, this will cause a myocardial infarction due to the lack of blood and oxygen to that specific part of the heart. So I want you to get a good view of a normal right coronary artery. So I'm just going to let that run for a couple more loops. Boom. This is what we don't want to see. You can see the catheter coming down from the 12 o'clock position, lined up or coaxial with the left coronary artery system delivering contrast. However, that contrast goes a few millimeters and completely stops. Not only do we have this narrowing or this tightness in this lesion, it's completely blocked, and all the blood flow distal to that blockage is preventing that myocardium from getting oxygen-rich blood. There's a lot of information I want to share with you today, but this slide might be the most important one. Time is muscle. For patients experiencing any sort of acute coronary syndrome, the mortality rate increases 7.5% for every 30 minutes that elapses before a patient with the ST segment elevation is recognized and treated. About 47% of sudden cardiac deaths occur outside of the hospital. This suggests that many people with heart disease don't act on early warning signs. It is incumbent upon us as radiologic technologists and healthcare providers that we know these basic common heart attack warning signs. Symptom to door times are from that time when the patient experiencing symptoms to the time they get to the door of the hospital can be shortened by recognizing these symptoms. And hospitals have a door-to-balloon time of 90 minutes. That means as soon as that patient gets to the door, our goal is to intervene in that coronary artery in less than 90 minutes. So I'm going to leave this slide up just for a second because it's critical that we all understand this. So our angiogram has revealed that we have a completely occluded right coronary artery. Well, how did this happen? Let's take a look at a cross-section of a coronary artery and the progression of disease. We'll start with a stable plaque, and we'll end with this totally occluded, in this case, right coronary artery. Acute coronary syndrome comprises a broad spectrum of obstructive coronary artery disease that most commonly arises from plaque rupture and erosion. This plaque prone to cause acute coronary syndrome has a thin fibrous cap, a large lipid pool, which is represented by those black areas, and is susceptible to disruption by inflammation and other factors. A clotting cascade is triggered inside the lumen of this blood vessel, leading to the formation of a blood clot, in this case, a thrombus. That thrombus can impede the flow of blood within a vessel. Severe thrombosis can block the flow of blood to a tissue, leading to ischemia and tissue death. We now have to remove that thrombus. Now our job is to remove that thrombus. But so far, all we've done is introduce contrast into that coronary artery in order to determine the extent and location of that blockage. Now the interventional section of our procedure starts. We're going to take a wire 190 centimeter long wire with the diameter slightly bigger than that of a hypodermic needle. We're going to introduce that wire into the catheter, then navigate it or steer it beyond the lesion in that coronary artery. And once we have that wire placed, we can begin to use that wire as a rail by which we deliver our interventional devices. So now we have to remove that clot, and we do that with an aspiration catheter. This catheter has 2 lumen wire so that we can deliver this tube through the catheter into the coronary artery, and it will track over that wire to the source of that thrombus. Once that catheter is placed there, we literally vacuum out that thrombus. So here's what we've done so far. We've replaced the diagnostic catheter with an interventional catheter. The doctor has navigated that tiny little wire by twisting and turning it with his fingertips through the catheter into the coronary artery, past the lesion, all the way out to the distal part of the right coronary artery. And you can see a tiny black dot where there used to be a lesion, it used to be a blockage. That is the aspiration catheter, and we're actually extracting or aspirating that clot from the artery. So now we've aspirated or removed that coronary clot in a procedure called a thrombectomy. Now this clot is sitting in this syringe that we created the vacuum with, and we strain that blood through those little baskets you see on the bottom right-hand corner, and we can actually see the formation of clot, the reason for the blockage for that right coronary artery. This is our post-thrombectomy angiogram, and we can see that we've restored blood flow to the distal right coronary artery. But we can see where that red arrow is. The cause of that thrombus still remains. That's a lesion that we'll address through a procedure called angioplasty. One more thing about this slide. Coming up from the bottom of this angiogram, you can see a transvenous pacing wire. We've actually inserted that into the femoral vein, placed it in the right ventricle, and now we're able to control or manipulate the patient's heart rate. Often upon revascularization of the right coronary artery, we see a condition called bradycardia. And in order to increase that patient's heartbeat, we're able to use this transvenous pacing device and actually control that patient's heart rate. We don't think about it very much in the cardiac cath lab, but the procedures, the techniques, the technology has been the result of contributors from around the world. Our patient has an occluded right coronary artery. We've cleared it of thrombus, but there's still a residual lesion or a residual narrowing of that artery. We can open up that artery permanently in an interventional procedure called angioplasty and stenting. And those procedures would not have been possible without Andreas Grunzig, who for the first time applied a balloon-tip catheter to a severely stenosed femoral artery, expanded that balloon, and restored blood flow. Years later, Jacques Puel from France was the first doctor to implant a coronary stent. So not only could we open that artery using a balloon, but we can also use a stent to make sure it maintains that lumen. So when you hear the word angioplasty mentioned, this is what we're doing. We're taking Andreas Grunzig's innovation, that balloon tip catheter, and positioning it exactly where that stenosis was. Then we inflate that balloon, compressing the plaque and widening the artery. We do so with the device you see on the left-hand side. It's called an indiflator, and it measures atmospheres of pressure. The more atmospheres of pressure I apply to that balloon, the more the balloon will expand. This is just a quick angiogram demonstrating the inflation of that coronary balloon. That coronary balloon is filled with a mixture of contrast and saline, and as I said, we expand it to a predetermined atmosphere, and we're pushing that artery open, and the plaque that may be associated with it is now up against the luminal wall, and we've restored the diameter of that coronary artery. So after angioplasty, we now put another balloon in. That balloon is very similar to the first one we used, except that it has the mesh wrapped around it. This small mesh metal tube acts as a scaffold that provides support to the inside of the coronary artery. Because remember, it wants to recoil. It wants to resume the same shape that probably over years it's become accustomed to. So we inflate that balloon, the mesh presses out against the inside of the artery, keeping it open. We deflate the balloon and then pull it out, leaving behind that metal stent. So let's take a quick look back. Remember, we had a fully occluded right coronary artery, and upon injection, we saw that the contrast only flowed into that artery a couple of millimeters. And here's the best part of the case. Here's our post-angiogram of the coronary intervention, and you can see that we've restored blood flow distal to where that artery was once totally occluded. You know, from the day when Warner Forsman, catheter dangling from his arm, went down those steps into the basement radiography department to document where that catheter was, the radiographer and the cath lab have been inseparable. But we're not in the basement anymore. Radiographers play an essential role in the life-saving procedures that take place in the cardiac cath lab every day. And it's a simple technology. Sheath, wire, catheter, stent. It's very simple, and yet we can apply that same principle across many patient populations. And perhaps the most exciting one is pediatrics. Congenital heart defects are the most common type of birth defect, affecting 8 out of every 1,000 newborns. Each year, 35,000 babies in the United States are born with a congenital heart defect. We often use the size of the fist to give patients and students an example of the size of their heart. Well, the same holds true for that of a baby. The latter half of my career, I focused on pediatric interventional cardiology, working on babies' hearts sometimes as small as a walnut. Those babies could comfortably fit on an 8x10 piece of paper. So as we look at the next couple slides, keep in mind that the images are highly magnified. I don't think there's a better example of the evolution of technology and procedures in the cardiac cath lab than valve replacement. Using the same techniques that we used when we were repairing a coronary lesion, we're actually able to deliver valves through a catheter or transcatheter valve replacement. So the next couple slides, I'll introduce you to that. Let's just take a quick look at the anatomy of a ventricle, and in particular, a valve. So I'm showing you this because I think it'll help you to understand the next couple slides in the procedure. So what we're looking at is a pig's heart, right ventricle, splayed open, and you can see the fingers on the bottom right-hand corner are actually squeezing or holding that myocardium. That's what we're depending upon, that muscle to push blood through this valve. And just above that, you can see the papillary muscles. Now, the papillary muscles work with the chordae tendineae, which are those white strands that are attached to the valve. Now, this valve's not functioning properly, so we need to replace it. But we're not necessarily removing it. We're taking a stent and we're pushing it to the side, much like we did when we cleared that total occlusion in the right coronary artery. But the difference between this stent and the one that we placed in the right coronary artery is that this stent, or this metal mesh, this metal tube, has a valve in it made from bovine pericardial tissue. It's hand sewn, and it comes as in a jar, as you can see, looking just like the image on the top. Then we actually take that valve and we use a special device to crimp it down on top of the balloon. Well, it's crimped down on top of this balloon, and for the same reason a stent is crimped down on top of the balloon when we address that right coronary artery. There would be no way to deliver it to its destination through a catheter, transcatheter, without it having a smaller profile, a lower profile. But once it reaches its destination, in this case, the valve that's not functioning properly, we expand the stent in exactly the same way as we did the coronary stent. It presses the old tissue or the old valve to the sides, and then when we deflate that balloon, we remove it, and we've left behind this artificial valve. I think as medical imaging professionals, we all have our favorite radiograph or our own favorite angiogram. This is easily mine. Let me tell you how we took this picture. We took that catheter that we described earlier, and we've placed it in the femoral vein, and we've steered that catheter up the IVC into the right atrium, through the tricuspid valve, into the right ventricle, then through the pulmonary valve and into the main pulmonary artery. Once that catheter is placed in the main pulmonary artery, we use an injector, and the injector injects a large amount of contrast because these are very large vessels, and we can see that contrast flowing out into the lung fields. Once in the lung fields, it returns back into the left atrium, where it is then put into the left ventricle, and all that oxygenated blood goes out to our body. Now, in this case, I want you to take a look at where that red arrow is. That's where the pulmonary valve is. Now, in a normally functioning pulmonary valve, there would be no contrast, where no blood flowing backwards, regurgitating into the right ventricle. So we're going to go about replacing this valve. So this is another example of a balloon being used in the cardiac cath lab. This time we're not using the balloon for angioplasty or to dilate a vessel to make it larger to enhance blood flow. This time we're simply using it for measurement purposes. So we take a rather large soft balloon, inflate it in the area of the valve, and that's represented by the letter A in this picture. So we're able to measure that to determine what size valve we should be placing in. And we're also looking at the area or the diameter of the pulmonary artery to give us an idea of how large this will have to be expanded. So we take a single frame, we go back in the control room and use a computer to assist us with these measurements. So in this particular case, it was determined that we needed to place a stent in order to displace the patient's own valve and create a more suitable environment for our artificial valve. Also gives me the opportunity to talk about biplane angiography. When we're doing pediatrics, we're using not only an AP view, but a lateral view. So we have two C-arms that are used for imaging that allows us to take some really precise measurements, and also allows us to do some angiograms and minimize the contrast load to the patient. So with one injection, we can see two different views. So here's a cool picture of us deploying the valve within this stent that we've previously placed there to create a more suitable environment for our artificial valve to live. So using an indeflator, the exact same procedure that we used when we were inflating the stent within the right coronary artery, we're slowly expanding that balloon, and that's done by increasing the pressure within that balloon. And we know at a certain pressure, that valve will become a certain diameter. So we're slowly injecting that contrast and saline into the balloon, expanding that valve and placing it in the patient. And this is just another graphic to kind of explain what we've just accomplished. So again, same techniques. It's kind of interesting. Sheath, catheter, wires, device. In this case, it's not just a stent, but a stent with a valve inside it. So we can see where it's placed in alignment with the patient's own valve in a crimped position. That stent is tightly holding onto that balloon. Until we can move on to the second picture. We've begun to put saline and contrast into that balloon, very precise increments, expanding that balloon so it successfully opposes the lumen of the pulmonary artery. And then we pull that balloon out. We deflate that balloon, pull it out, leaving behind the patient's new valve. So let's return, take a quick look at the angiogram before. Here's the before picture. Take a look at where that red arrow is. You can see that regurgitation, that insufficient valve, allowing contrast to flow back into the RV. So here's our post-intervention angiogram. I like this picture even more because look, there's no contrast, no blood flowing back into the right ventricle. We've deployed that valve through a catheter using the same techniques that we used when we're deploying stents within coronary arteries. Most of us know the name Thomas Alva Edison, a prolific American inventor. But fewer of us know he invented fluoroscopy. And even less people know the role of Clarence Madison Dally. See, Clarence Madison Dally was a glassblower, and Edison relied upon him to create the fluoroscopy tubes. They set about their work in 1896. But by 1900, Clarence started suffering radiation damage to his hands and face. By 1902, one lesion on his left wrist was treated unsuccessfully with multiple skin grafts, and eventually the left hand was amputated. An ulceration on his right hand necessitated the amputation of 4 fingers. These procedures failed to halt the progression of his carcinoma, and despite the amputation of his arms at the elbow, he died from mediastinal cancer. Dally is thought to be the first American to die from the effects of experimentation with radiation. After Clarence's death, the great American inventor ceased all production on his new fluoroscopy system. He was quoted as saying, "Don't talk to me about x-rays, I'm afraid of them." Edison was also quoted as saying, "I do not want to know anything more about x-rays. In the hands of experienced operators, they are a valuable adjunct to surgery, locating as they do objects concealed from view and making, for instance, the operation for appendicitis almost sure. But they are dangerous, deadly in the hands of the inexperienced." So what you've seen so far are some of the amazing things we're doing in the cardiac cath lab. We're opening up blocked arteries, restoring blood flow to the heart and saving lives. We're replacing valves through tiny little holes rather than open heart surgery so that babies can thrive. But all of that is only possible through the use of fluoroscopy. And with fluoroscopy comes dose. So this is an oversimplification, but I think it helps put in perspective the kind of radiation dose that we experience in the cardiac cath lab. If we assume that a chest radiograph is 0.02 millisieverts, when we perform a coronary angiography, it's the equivalent dose of 155 chest radiographs. When we place a stent, as we did in the patient with the occluded artery, that's 755 chest radiographs. And when we do an iliac angioplasty, a procedure very similar to what Andreas Grunzig did first in Germany, that's 2,900 chest radiographs. Radiation-induced skin injuries happen very rarely, And a rough estimate is about 1 in 10,000 interventions. And you can see along the bottom 4 pictures the effects of radiation dose on the skin. Now, we all have learned about radiation safety for the patient, but what's concerning, especially to me, is the safety of those performing those procedures. And that's what we'll talk about in the next few slides. As a radiographer in the cardiac cath lab, this is one of our greatest challenges. The source of our radiation is not fixed as it is in a regular chest x-ray. It's attached to a C-arm, and that C-arm is constantly being repositioned to provide the optimum image for the cardiologist. However, each time we move the C-arm, we're changing dose, not only to us, but we're changing the scatter fields. This makes shielding particularly difficult, and it makes radiation safety not only for us, but those in the room challenging as well. But it's incumbent upon us as radiographers to take this responsibility, because if we don't take this responsibility, no one else will. And what are the effects to this exposure to radiation? Well, there's mounting evidence that shows a link to a series of significant stochastic health effects. Left-sided brain tumors, skin cancer, posterior subcapsular lens changes, thyroid disease, neurodegenerative diseases, and cardiovascular disease. Not for our patients. These are being reported by interventional cardiologists, nurses, and cardiovascular technologists. So although that list of stochastic effects can be startling, those aren't among the most prevalent career-limiting factors we face in the cardiac cath lab. Let's take a look at this list. Orthopedic illness, 30%. Hypertension, 13%. Anxiety and depression, 12%. And then we can go on down the list. So right at the top is orthopedic illness, but here's something I want to mention. Anxiety and depression. People die in the cardiac cath lab. It doesn't happen all the time, but when it does, the aftermath looks something very similar to this. You have a team of professionals who maybe worked for hours trying to save someone's life. And I can't tell you how emotionally impacting that can be. I teach my students that one of our first obligations is to ensure that patient is as comfortable as possible. And that involves speaking to them. I talk to them about the weather, what they do, their family, their friends. And many of those times, I was the last person that patient ever spoke to. And yet when a patient expires, I've never seen any consistent policies or procedures in place to deal with the emotional aftermath of that. We've got to do a better job in that area. Time, distance, and shielding. 3 basic principles of radiation safety. Most of us learn them in our first week in radiography school. Let's see how they apply in the cardiac cath lab. Time. The less time we're exposed to a source of radiation, the less dose we'll get. But in the cath lab, we're using more and more radiation as a result of procedures getting more sophisticated. In fact, we often see radiation or total fluoroscopy time in excess of an hour. Distance, run in the other direction. The farther we are from that source of radiation, the less dose we'll get. Yet in the cardiac cath lab, we're standing literally inches from the source of radiation, the C-arm. And shielding. Shielding, great concept, as we'll see in the next slide, but it doesn't have a lot of application in the cardiac cath lab. Shielding can be particularly challenging in the cardiac cath lab due to the need for the operators to have access to the patient and also for the C-arm to move around that patient. So as we can see in example A, those shields, although they're placed nicely, are just not realistic within a cardiac cath lab. In example B, we can see the radiologist or the cardiologist behind a moving shield injecting contrast. It's a great practice. However, someone now has to come into that sterile field between the doctor and the patient and remove that shield when the cardiologist wants to continue with the intervention. And C, we see a nice placement of a shield where we have a circulator or a nurse or a radiologic technologist injecting medication into that patient. However, the bottom shield is the best example. Ceiling mounted shields reduce operator radiation from 64% to 98%. And in fact, the ceiling mounted shield protection was better than lead glasses and other radiation shielding drapes combined. And it even gets more challenging. As these procedures evolve, they're requiring us to stand closer and closer to the source of radiation. Let's look at example A on the top. Femoral access placed our hand somewhere around the midsection of the patient because we were working through the femoral artery. But now we're starting to do more and more cases through the radial artery, which requires us to move to the left, closer to the source of radiation. And we're seeing even an increase in the number of procedures that require internal jugular vein access. That places our hands almost directly in the beam of the X-ray source. As radiographers in the cardiac cath lab, radiation safety can be particularly challenging because of its complexity. However, one of the simplest things we can do for ourselves and for our coworkers is to ensure that their lead fits correctly. Regardless of design, it's important that the garment fits properly, particularly at the left armhole. Large gaps could result in increased exposure of breast tissue, which is especially important for the female staff. Now keep in mind your positioning at the procedure table. We're facing the monitors, which are directly in front of us. The source of the radiation is at an angle to our left. So as we reach and do the activities that are expected of us during procedural assistance, we're exposing that armhole to radiation. Let's be the experts in the room, not only for us, but for the people that we work with. So when our protective garments fit properly, they do an amazing job. These garments are designed to protect the gonads and 80% of the active bone marrow in our body. And at 75 kVp, a 0.5 millimeter lead protective garment reduces our exposure 99%. However, there's big differences between the two styles of lead that you see in the pictures on the right. The yellow one is a one-piece garment, which means that all of the weight of that garment is solely resting upon your shoulders. In the blue example, we see that we have both a vest and a skirt, a two-piece garment. So on the top, half of the lead is being supported by our shoulders and the other half on our hips. And that's particularly important when we talk about orthopedic problems that are encountered in the cath lab. There have been significant improvements in our personal protective garments in the cardiac cath lab. However, because of their weight, they still pose a significant risk to our orthopedic health. Wearing a 15-pound lead apron can induce pressures of over 300 pounds per square inch on our intervertebral discs. And among interventional cardiologists, 60% of them experience spine problems, compared to 26% of those with shorter terms in the cardiac cath lab. In 2004, the SCAI found that over 25% of respondents experienced significant pain in their knees, their hips, and their ankles, and more than 50% of interventional cardiologists require some kind of treatments for spine symptoms. Not all of the advancements in personal protective gear focus upon the weight of those garments. Your thyroid shield is one of the most sensitive organs in the human body when it comes to radiation exposure. However, many of us are not wearing radiation shields, thyroid shields, that properly fit us, and when we are, those shields were manufactured using a process that created holes in the radiation shield directly above our thyroid gland. So we're starting to pay attention to details, which is good for us, and we should be focusing on wearing radiation thyroid shields that are visor style, that don't create or don't have any holes specifically over the areas that we're trying to protect. Now, as radiographers in the cardiac cath lab, we have to be aware of these developments, not only for our own safety, but for the safety of those that we're working with. As radiographers in the cardiac cath lab, we know that dose reduction employs far more than simply entering the correct variables into the fluoroscopy system. We can have a tremendous impact on patient dose and on scatter to our coworkers by focusing on the geometry of the system. And table height is a simple example of that. On the left, the physician performs a procedure with the table elevated and the image intensifier close to the patient. In the center, the physician employs a table sitting but maintains the image intensifier close to the patient's chest. Because of the closer proximity of the X-ray tube, the dose rate to the patient at the beam entrance port will be about 40% higher. On the right, the physician employs a low table height but has elevated the image intensifier. The skin dose to the patient on the right is 260% that of the patient on the left. The image generated by the configuration on the right is 40 to 50% larger owing to the geometric magnification caused by the elevated image intensifier. If the procedure on the left required 3 gray skin dose, the same procedure employing the center configuration would result in 4.2 gray dose, whereas the one performed employing the configuration on the right would result in 7.8 gray. So by focusing on table height and focusing on CR magulation, we're controlling the geometry and we're controlling radiation dose. So in the previous slide, we saw that raising the table can reduce patient dose. However, the consequences of that is it often raises the curtain, protecting our lower limbs off of the floor, exposing our lower limbs to radiation. Researchers found that without protection, the lower limb dose was frequently greater than the hand dose, with a mean leg dose between 0.19 and 2.6 millisieverts per procedure without any protection, and between 0.02 and 0.05 millisieverts per procedure with a protective curtain. The exposure is attributed to the presence of the gap between the protective curtain and the floor, the size of which is dependent upon the height of the treatment table. So to combat that exposure, now we're starting to adopt shin guards, radiation protective devices for our lower leg. We're starting to see an increase in the popularity and the availability of skull caps as an accessory radiation protection device in the cardiac cath lab. And that's for good reason. A recent study found that during diagnostic coronary angiograms, assistants received 41% more occupational head dose than the cardiologist and 52% higher head doses during interventional cases. The cap reduced radiation to some tissues of the face and neck by approximately 65% to 70%. However, the level of protection was only 4.9% to the left brain, and 1.8% to the right brain, and 3.3% to the whole brain. And researchers have concluded that absorbent surgical caps provide minimal brain protection. It is extremely important that we wear eye protection in the cardiac cath lab, and that's for 2 reasons. Number 1, we're reducing the possibility that we may get splashed in the eyes with bodily fluids or blood, and number 2, it reduces our exposure to radiation. In a recent study, 41% of cardiac cath lab nurses and technologists had significant posterior subcapsular lens changes, which were not age-related and are typical of ionizing radiation exposure. Another study showed 21% of nurses and technicians had radiation-associated posterior lens changes. And although the materials that we're using are very effective in blocking incident radiation, most of the glasses evaluated reduced eye dose by only 30 to 88% due to radiation backscattered in the head and oblique incident radiation. So again, we see the importance of recognizing that we're facing forward while the source of radiation is to our left. So for the same reason it's important to have our left armhole in our lead garment fit correctly, it's important that we have protection on the side of our glasses and not merely the lens itself. And you can see great examples of protective eyewear that protects you from this oblique incident radiation in example number 2 and example number 3. Unlike other areas of medical imaging, the radiographer should not be in charge of activating the imaging system in the cardiac cath lab. That responsibility is solely upon the primary cardiologist. Radiation exposure during fluoroscopy is directly proportional to the length of time the unit is activated. And it is impossible for us to predict, as radiographers, when the cardiologist will be looking at the screen. If we attempt to do that, the result is almost always longer cine runs and fluoroscopy runs that are necessary. So we should advocate, in fact insist, that the doctor operate the pedal to reduce patient dose and reduce scatter to everyone in the room. So why is the cath lab such a challenging environment for the cardiac cath lab radiologic technologist? As we look over this list of responsibilities, of things we have to be aware of to ensure that radiation safety of the patient, of our coworkers, and ourselves, we also have to maintain the skills and a knowledge base necessary to provide assistance while we're clearing blockages from people's arteries that saves lives, while we're replacing valves that allow children to thrive. And we do all of this on a daily basis in a cardiac cath lab. Thank you all so much for joining me today. I hope you enjoyed my presentation. And I have to tell you, this has been one of the greatest thrills of my life to be able to share this information with you. I look forward to meeting you all someday, but in the meantime, please use this information to contact me if you have any questions. Have a beautiful day.
Appa, you're muted.
Thank you so much, Chris, for your very, very comprehensive talk. And for the audience from home, either you on this Zoom platform or on the Facebook Live, you can ask the question if you want. It's going to be the chat box underneath the screen, or it's going to be on the right-hand side of the screen, depending on the platform that you are. And I just got some questions from the audience already for Chris about about his talk. The first one is when is difference in delivery of dose between adults and pediatric patients? That's the first question I got from the audience. Chris.
Sure, it's a wonderful question. Dose is much higher in adults. If we're looking at patient density and the amount of hard tissue or bone that we have to penetrate in order to create an image. So we see increases in dose. Now we would assume that we'd see the same decrease in dose in pediatrics. However, since we're using biplane or two sources of radiation to create images, the patient doses to pediatrics can also be just as high. But the same as we would see higher doses in thicker patients in static radiography or chest radiography, for example, because of the density in adults, we see higher doses as well in the cardiac cath lab.
Oh, all right. And I got another question. In the practice in the US, in the cath lab for interventionists and for technologists, when you put on the personal dose monitoring, either it's going to be TLD or the OSL, for technologists, do you put 2 badges or 1 badge?
That practice varies from laboratory to laboratory. However, best practice would be to wear a badge dosimeter at the thyroid level, and also one inside of your lead
Yeah.
at waist level, so that we can compare those two measurements for dose.
All right, that's great. And the third one is, I think I just got the new one. Oops. Do you still need to drape, shield if your protective garments fit properly already?
Absolutely. Shielding is essential. Time, distance, and shielding, although it's difficult in the cardiac cath lab, still applies. So every tool that we have available to us to protect ourselves from radiation, we should be using. And that includes both shielding and our own protective garments.
Okay, and when it comes to the practice, I think for the radiologic technologists and for radiologic technologists who work in the cath lab in the U.S., do you need extra credential on top of the credential that you have to perform X-rays as a radiologic technologist to work in the cath lab?
That again is dependent upon local requirements, hospital requirements. In the United States, we have 2 credentials for cardiac cath lab specialists. One, of course, being the ARRT, cardiac interventional credential, which is in addition to you being a radiographer. So that would be a secondary credential. And we also have a cardiovascular invasive specialist credential as well for technologists. So there are actually 2, but both of them focus very highly on radiation safety.
All right, that's quite interesting because practice from one place is different to another. I think we're gonna have another episode on this, not only cardiac intervention, but on interventional radiology, also on the role of radiographers and technologists, and that's gonna be after New Year. We will announce that. Donna, you have any question or comment so far?
No, I think it's great. I would be interested in hearing that, Mike, I know that you are an RA and you have to deal with radiation protection to pediatrics. I know that you are in a pediatric facility, and do you have to do work with ensuring radiation protection happens with the pediatric population differently than the adult population? Can you let us know what's happening in the United States in that area in your facility?
Sure. Yeah. We certainly kind of make sure to take very extra care with our pediatric patients as far as radiation protection goes. Like you had said, most of what I do is pediatric fluoroscopy. And so we make sure to do certain things to keep the dose low for kids. With fluoroscopy, lowest possible pulse rate on our fluoroscopes, as well as making sure that we actually keep the grid out. We're not as worried about scatter degrading our image quality in pediatrics. So those are just those are a couple of the very big things that we do to keep the pediatric dose low.
I have another question, Napa. I think I would be interested to hear from both Chris and Mike. Mike or Chris, you can go first, but I'd be interested to know, I heard during the talk, the discussion about wearing the lead glasses with the side shield on them, and then that the protective wear of the garment that you wear being the waist and the top is better than the full shield. So I would be interested to know in your guys' practice, are you seeing the lead glasses without the side shields going off the market, and the single garment going away? Or is this a cost prohibitive thing and that we're seeing both in the market? So I'd be really curious to know in the United States what we are seeing.
Sure. I think that everyone wants to wear the cool looking glasses. Mm-hmm. And those are the ones that without a side shield, not to mention any brand names, but they look lighter, they look cooler. But really, if we consider that the radiation dose is coming from the side of us and not straight ahead, we want the glasses with the side protections. And despite the best efforts of many, the lighter shieldless, side shieldless glasses are far more popular. And that's where I kind of reiterate that this is our responsibility as radiographers. It is our specialty, medical imaging and radiation safety, and we really must be proactive within the Cath lab to demonstrate our expertise. Or as Michael said, there are encroachments by other professionals who don't have this background. So we're losing that insight, and the glasses are a great example of that. Referring to the lead, we try to encourage people to wear two-piece lead simply because of the weight distribution. Although the single-piece lead is quite popular because it's easy and it's convenient, but it's heavier. And so we have all of that weight on our shoulders, and that's a significant reason for the orthopedic injuries that we see in the cardiac cath lab.
All right. I think I got very interesting questions from the audience, at least 3 people asking about radiation dose management or dose monitoring. I just want to hear the practice. What are you doing at the moment in terms of like dose threshold management and things like that for the skin reaction?
Sure. What's been interesting lately is traditionally we've been using traditional dosimeters to measure dose, but in the last few years, we're starting to see our real-time monitoring of our dose, where we can go in with badges and perform our cases, and then upon leaving the room, we can enter these badges into a monitor and get an instant radiation reading of the dose we just received. So it allows us in almost real time to make adjustments to our practice. Instead of having to wait a month or 3 months to get reports on radiation dose, that immediate feedback of having those numbers immediately after the case allow us to make changes to our practice that we can incorporate into the next case without having to wait months to make those adjustments. So we're seeing a lot of advances in that area.
Yeah, and back on
Yeah,
the patient side, Donna, do you want to say something?
I wanted Mike to just about the ASRT. I know that they have some great projects. They have some their practice standards where they talk about some of these. They've collaborated with some organizations. Can you talk a little bit about just for sharing for other professional societies what ASRT has done with dose reduction and their practice standards if member societies are looking for ways to actually incorporate things?
Oh boy, that's a good one. So, we, like I had said a little earlier, a big part of what we do for our members is provide continuing education or, education modules that people can read to help get them up to date. Because I know when I started in radiology, I started my training in radiography in 1995. So 25 years ago, and things are a whole lot different now than they were then. If you look at the dose reduction that we've been able to achieve with digital radiography over film screen, that's a big thing. And so, we have collaborated with other organizations and also in our practice standards, developing standards that are more up to date and more appropriate for today's technology, which, like I said, is quite a bit different, certainly even than just 10 years ago.
All right, very interesting, and come back to the question, but it's back to the patient side about patient dose monitoring, and people want to know about the current practice in terms of monitoring the dose and the threshold dose. To who report this? Say if the patient skin dose exceed 3 grays or 2 grays, depending on your institute set up the threshold, does Radiologic Technologist has a role on this?
Well, it's their primary function. So in addition to doing the roles of procedural assistance, we're looking at the monitors right next to the images that we're creating. We're looking in real time changes in dose. And it's quite fascinating when you watch the dose and simply moving that tube to different angles. And as we pan or move that patient in order to capture the images that we need to see, we can actually see the changes in dose in real time. But in the United States, we usually have a 5 gray limit. So when 5 gray limit occurs, we have to report it as an event, not only within our own department, but to the radiation safety officers.
All right.
So I can't reiterate this enough. It is the radiologic technologist's responsibility to ensure that happens, and to be a constant reminder as to what changes can be made in angulation and in geometry to reduce dose to that patient.
Yeah, that's great. Donna, you have anything else for tonight?
I do not. I would
It's
just
been
like,
great.
yeah, it is phenomenal. And I just can't thank the ASRT and Mike Ogren, my good friend, for actually taking time to collaborate and co-host this great webinar. We like to do more in the future, and we appreciate that you guys are leaders within our profession in the United States and also within the ISRT. You have been great collaborators, and you're always willing to help out. And so we appreciate your experience, your knowledge, and your background that you've shared with professionals from all over the world. And to Chris, I can't thank you, my good friend, for putting this presentation together. I appreciate that you share your expertise, that you have much to share with the world in radiation protection and in the field of cardiac. And so I thank you for doing this for us. You have always been a wonderful leader and always collaborating with us when we ask. And Weber State as well, because they have always been a great collaborator for us. And we hope to do more of these in the future. So we appreciate everybody tuning in, and I'll turn it back over to Napa.
All right. I just would like to have a last word from Mike before we go back to Chris for his last word. Mike, it's your turn.
Oh, thank you. I guess I also want to say a big thank you to the ISRRT, Donna, Napapong, Yudafong, and really to Chris. Chris, that presentation was fantastic. I know I learned a lot of things that I'd never even heard before. I've never worked in the Cath lab, and I really appreciate you taking the time to educate all of us really around the world with this presentation. So thank you, everybody. Thank you.
Thank you, Mike. And now we are back to our guests, our speakers for today, Chris Tillman.
I would just like to close by saying what a privilege and an honor it is to have the opportunity to share this information. You know, a lot of my life has been dedicated to increasing access to education for those of us who don't regularly have access to it. And through Donna's Newman's leadership and the work of the ISRT, we've really taken great strides in making information available to the world. And for me, and to see this happening, I could not be happier. So again, it's been a privilege to be part of this, and just want to thank everyone.
Thank you so much, Chris Tillman. And I would like to conclude tonight or today's event that we will come back next year. We will have a little break before we go to the next episode. It will be about role of radiographers and technologists on interventional radiology and cardiology. And we will invite our colleagues from all around the world to share their experience on this. And this will be another exciting episode. And until we meet then, happy holiday, Merry Christmas, and Happy New Year. And for today, thank you, everyone, and goodbye.